So, oh, okay, sorry about that. So hi, my name's Manu. I'm one of the core trainees currently in surgical training. So this presentation is about surviving your surgical on call. We will mostly be doing case-based presentations because that's kind of the best way to learn about common pathologies that you'll mainly find on your surgical on calls. I hope it's helpful for you guys. And I think it'll be helpful for anyone, even if you are a medical student, F1, F2, even some core trainees. Probably less helpful for registrars, but it's a good starting point. Okay, so we'll crack on. So just a few words about us. So we're the Yorkshire Foundation Trainee Surgical Society. We're a newly created organisation and we're associated with the Royal College of Surgeons of Edinburgh. So we've got a core committee, mainly of F2s, and I'm one core surgical trainee. And we've got a team of friendly registrars and Royal Society advisors to guide us. Our main aims are to improve access to high quality surgical education, affordable and relevant surgical courses, collaborative surgical audit and research opportunities, providing support for portfolio and career development, and to promote and encourage foundation trainees and medical students to pursue a surgical career. So we're going to aim to do this by providing a series of events throughout the coming year. So please stay tuned on our social media channels. We've also got a mailing list, which we'll provide later on in the presentation if you're not already on it. So again, like I said, the presentation is going to be recorded and it'll be freely available to view at a later date. So I hope you enjoy it. Okay, so just to start us off with, we've just got a slide on task prioritization. So like the slide says, you've just started on your night shift. You've been handed over the following jobs. Chase bloods of a 74-year-old male who was stepped down from ICU today after he underwent esophagectomy 5 days ago. A cannula, and to clerk a new patient who has arrived for an operation tomorrow. So thinking about this, you probably need a bit more information before you can decide what you're going to prioritize to do first. Let's start with the first one, chasing bloods. So we know that this chap has been stepped down from ICU. So he's likely stable from a medical point of view. He's also had an operation 5 days ago, so he's unlikely to have any future operations unless he's medically unwell or is acutely unwell. So unless this chap is acutely unwell or there are jobs that you need to do for him, this is probably going to be lower on your prioritization list. When we move to cannula, we need to know what the cannula is for. Is it for an acutely unwell patient? Do they need fluids? Is it for time-critical medications, such as your anti-epileptics or your Parkinsonian medications? Or is it for a medication that's not going to be given until 9 a.m. in the morning? In which case, if it's for the latter, it's going to be less urgent. But if it's for the former, it's going to be more urgent. So just make sure that you get a bit more information. And then moving on to the third one, clerking a new patient who's arrived for an operation tomorrow. This patient, we know that this patient's going to have an operation tomorrow. So they're going to need bloods. They're going to need a coag and a group and save if they need blood and theatre. So clerking them is probably going to be high up on your prioritization list. They're probably going to be nil by mouth, so you probably need to prescribe them fluids, in which case they'll need a cannula. And make sure that they have their medications prescribed. So you've decided to get started with your first task, and then you get called to review one of the ladies on the ward. And just to mention, guys, so we're going to be using an application called Mentimeter throughout the presentation. Each case has a different Mentimeter thing attached to it. So if you just go on to menti.com, and then when we go on it, it will have a list of numbers that you can put into the thing on your phone. And then you can answer the questions. If you don't have it, it doesn't matter. You can answer it in your head or you can type it into the chat box. Okay, so like we said, probably a large part of your job as an on-call foundation doctor is going to be reviewing unwell post-op patients, especially on acute gen surg wards. And it's either going to be you're reviewing them on the wards or you're clerking them on the take. So this is the following case, kind of highlighting an acutely unwell patient, and it's something that you might come across. Okay, so we've got a 77-year-old lady. She's got a background of COPD, She's got high BMI and she's a heavy smoker. She says that she has a 7-month history of weight loss and fatigue, but 5 days ago she began experiencing an inability to open her bowels. So her abdomen's become progressively distended, and she's experiencing generalized tenderness. When she was admitted, she's began vomiting and she's unable to keep food down. So just thinking about that in your head, about she's not able to open her bowel, she's distended and she's vomiting, and she's had weight loss and lethargy over a period of 7 months as well. And she's a heavy smoker. So you're not going to be expected to interpret CT scans as an F1, F2, even a CT. You're just going to be expected to kind of take a good history and examination and be able to come up with a list of differentials and how you're going to investigate it. But we're looking at the CT scan right now. We can see right-sided thickening and there's obstruction. The distal bowel is collapsed from the transition. There's a transition point and the distal bowel is collapsed. So most likely this is caused, from the history, it's caused from an obstructing right colonic tumour. So this lady is going to have a laparotomy, and she's had a right hemicolectomy with end-to-end primary anastomosis. So what that means is her bowel has been removed from cecum to transverse colon, which you can see in the diagram here. And she's had both ends sewn up together. So the terminal ileum is sewn up to the transverse colon. You can also use staples. Okay, so day 1 post-op, you see her on the ward round. She's sat up in bed. She's got a nasogastric tube on free drainage and a Robinson drain on the right side of her abdomen. She's catheterized and seems comfortable. At 11 a.m., you're called to see her by one of the nurses. She's spiked her temp and she's tachycardic. What do you do? So if you guys go onto the Mentimeter thing, at the top of the screen, you should see a code. If you just put that in, and then you can answer the questions, and I'll wait for a minute while you guys do that. Okay, I'm going to start. Okay. So the question is, what is your first step in seeing this patient? So you're going to send bloods and cultures as part of your sepsis screen. Are you going to check the temp again, give some paracetamol, or are you going to do an A2E assessment? Great. So most of you said your A2E assessment. So most of these things are probably, you know, useful, but your first thing that you want to do when you're assessing an unwell patient, and I'm going to hammer this home because it's really important, you need to do your A2E assessment. And the reason why it's important is because you need to assess how unwell is this patient. If they have airway compromise, then, you know, you need to get senior help. You need to probably put out 4-2s. And while you're doing your ATE assessment, you can treat them initially. So you can give some oxygen, or you can give some fluids, or, you know, there's a lot of things that you can do during your ATE assessment. Okay, so I just want to hammer home the point that the first thing you do when you see an unwell patient, you've already got information from the nurses, you've taken the handover, you said you're going to see them, you're going to do your ATE assessment. Okay, so going back to the presentation, and then we'll go back to the Mentimeter, so don't turn it off right now. So you're assessing her, you're doing your ATE. You come and see her, At the end of the bed, you see that she looks a bit flushed and she's a bit uncomfortable. However, she's speaking to you in full sentences, so straight away you know her airway is not compromised. Her oxygen sats are 97% on air. There's no signs of respiratory distress. When you auscultate, you think you can hear some crackles in the right base. They don't clear when you ask her to cough. She's peripherally warm. She's got a tachycardia of 115 beats per minute, and it's regular rhythm. There are no other signs of cardiovascular compromise. You palpate her abdomen, and you note she's tender in the right side, but there's no signs of peritonitis. You've seen that she had a Robinson drain, and she has around 50 mils of Haematuria fluid in it. The rest of your examination is unremarkable. So you've noticed she's got a pyrexia of 38 degrees. You give her 1 gram of paracetamol IV. You take a new set of bloods and cultures. Your reg is in theatre attending to a complicated case. So you make a note to ensure you speak with them when they come back. And then you also do a sepsis screen in preparation. So you'll do a urine culture and a chest x-ray as well. So you request these investigations, and then you go off and you do the rest of your jobs on the ward. So at 9 p.m, let's say that you're on a 10 till 10 shift. 9 p.m, you're called to see her again by the nurses who are quite worried about her. They said that she spiked another temp and she looks really unwell. So what are you going to do? So again, you need to do your A to E assessment. It's really important, you know, when you first see an acutely unwell patient, that you do A to E, because it's going to tell you just how unwell the patient is, and there might be an indication of what is actually going on as well. So you assess her. When you see her at the end of the bed, she's sweating profusely. She's evidently in pain. She's talking to you, which means that her airway is patent, but she looks distressed. Her sats have dropped now. She's 90% on air. She's tachypneic. She's still got right-sided creps. Peripherally, she's cooled and clammy, but her tachycardia has increased. She's now 140 beats per minute. It's still regular. Her blood pressure now has dropped to 80/45. She looks dehydrated and hypovolemic. You palpate her abdomen again, and she's tender on the right side, and there's evidence of rebound tenderness. You look at the drain, and now the contents show dark, thick fluid, and the rest of the examination reveals no abnormalities. So what are you going to do? So while you're doing your A to E, you're going to find these abnormalities and you're going to treat them as you go along. So you treat it. So you're going through, you notice airway's fine, breathing is a bit bad, so we're going to pop her on 15 litres of non-rebreathe oxygen. And she's tachypneic, so hopefully the oxygen's going to help. The other thing is her blood pressure is really low and she's really tachycardic, so she's really dehydrated. She needs fluid resuscitation. While you're doing this, you're going to keep reassessing your A to E, because there's no point just doing your A to E and saying I'm done. You need to reassess every time you make a change. So you put the oxygen on, you check again to see if the sats have come up. They've come up to 97% on 2 litres. You've given a fluid bolus of Hartmann's. However, her blood pressure hasn't improved, so you continue to fluid resuscitate her. Despite fluid resuscitation, her BP is not improving above 90 systolic, and now her oxygen sats have dropped again to 92% on 2 litres. So going back to the Mentimeter, what will you do next? So you're just going to give her more fluids? Will you request a CT? Are you going to escalate, or are you going to just observe her for another half an hour? Great. So all of you said that you're going to escalate. And I think that's really important, because you know your limits of competence. This patient is really unwell. Their BP is not improving despite numerous fluid resuscitation attempts. So they may need, they're tachycardic. They have multiple systems aren't working. So they might need critical care support. They definitely need a senior review. So it's definitely important to escalate to your seniors. Okay. So you have escalated, and you have, sorry, let me just go back. So you're going to escalate to your seniors, and you've said that you treated them, you've taken the bloods, and they're not really improving. So what do you think the diagnosis is? So noting that she's got multiple systems that are failing, she's pyrexial, you've heard her abdomen is tender, and you've also heard creps in the lungs. Cool. Anyone else? Yeah. Great. Yeah. Great. These are all great answers. And any one of these can be true. So thinking about it more broadly, great. Really impressed. Well done, guys. So thinking about it more broadly, we're thinking that this patient is in shock because they've got multiple organs that are failing. It's treatment refractory, and she's pyrexial, so it's likely that she's septic. And you guys have given really good differentials in pneumonia, perforation, and anastomotic leak. So great. Okay. So looking at this chest X-ray, you can see that the patient has right-sided basal consolidation. So pneumonia may be the source. However, we know that she's peritonitic and her abdomen is really tender in the right side. She's day 7 post right hemicolectomy with primary end-to-end anastomosis. So as a few of you already mentioned, anastomotic leak could also be happening. So it's not necessarily just because she has one organ system that is failing, doesn't mean that she might not have another organ system that's failing. So you do a CT abdomen and it shows an anastomotic leak. And because some of you have already mentioned it, I assume you know what it means, but just to hammer the point home, essentially what's happened is the anastomosis, where the terminal ileum has joined to the transverse colon, has failed. There might be a number of reasons for this. It might be poor perfusion, the mucosal apposition might not be great. However, it's failed and it's leaking, and there's gastrointestinal contents going into the abdomen. That causes, in this case, this lady has peritonitis, so she has fecal peritonitis. So she gets taken to theatre for takedown of her anastomosis and a washout. She's given antibiotics, was going to treat both her chest and her abdomen, and she makes an uneventful recovery henceforth. We've already discussed this, so I'll leave this question out. Okay. So the main learning points that I want you guys to take home are that post-operative complications are common, and it might be related to the procedure, it might not be, there might be a number of things going on. It doesn't necessarily mean that just because you can hear right basal creps that you should ignore the abdomen as well, because this patient has 2 different things going on. And post-operatively, patients might not be on adequate pain relief, so they're not aerating their lungs correctly, they get post-operative atelectasis, and they're more predisposed to chest infections, but also other operative complications can occur at the same time. So some are specific to the speciality. You need to know the common and serious ones, and when you need to know when to escalate. You're going to be the first one to assess these patients, right? So you need to be able to perform a good A to E assessment and make sure that you're trying to stabilize the patient. If you can't stabilize them, then that means that you definitely need help. You should also, if you've stabilized a patient who has been unwell, you should definitely let your registrar know that you've seen this unwell patient, because they want to know about their patients that have had procedures. Always follow your A to E, and it won't let you down, and make sure that you escalate early on. Okay, so moving on to the second case. So you're bleeped at 3 a.m. to see this patient. This is the handover that you're given. Please can you review Morris Smith in bed 17? He's in a lot of pain and his urine is an odd colour. So you ask for a bit more information because it's not really much to go on. However, they've not got any more information because they've been admitted, they've just been admitted and they've not been clerked yet. And the handover from ED just said admit surgeons. But the nurse can tell you he's a 76-year-old chap, He's screaming in pain, he's clutching his stomach, and his urine is a bit pink. He's got a background of hypertension, he's obese, and he has a metallic heart valve. So what are you going to do in the situation? How are you going to assess the patient? Your A to E, which is going to be a common theme throughout this presentation. So this patient he looks flushed. He's asked for a vomit bowl. He says his pain started suddenly. It's the worst pain he's ever had. It's worse than when he broke his hip. He says it's coming in waves and he feels nauseous, but he hasn't been sick. He's tried paracetamol and codeine. They haven't really helped. And he last had them 8 hours ago in the emergency department. He's worried that his urine is pink, and he says that the emergency department put in a catheter because he was in pain, and then it got a bit better, but then now the pain has returned and it's worse than ever. You examine him, you know his airway is patent because he's talking to you. Breathing is unremarkable. You notice that he's slightly tachycardic, his heart rate is 115, and he's a bit hypertensive. He's alert and orientated. When you examine his abdomen, you notice that he has suprapubic pain on palpation, and he tells you that he's having loin pain that's radiating to his groin. He's voluntarily guarding, and he's got bowel sounds. You note that he has the catheter in situ, and it's draining a good volume of pale pink fluid. You've asked for a urine dip, and there's plus bloods, and no nitrites and no leukocytes. So with that information, what investigations and management do you think are appropriate for this patient? So we're going to go back to the Mentimeter, and you're going to need to put in a new code, which is at the top of the screen here. So I'll give you a minute to do that. Great. Okay. So what investigation do you think you want to do for Mr. Smith first? Okay, so the majority of you have said FBC, clotting, and group and save. I think there's been a mistake, and we should have written a UNE as well on that. So essentially, you want to do a full set of bloods. An ABG, yes, it might be useful to look for a HB, but it's a full set of bloods is going to tell us a bit more information than just an ABG. Urine dip we already have, and we want more information than just a UNE. So we consider group and saves when we think we're gonna, if we think we're gonna operate, because the patient might need transfusion, or if the patient needs a transfusion. A clotting because they are obviously bleeding, and FBC we need to know the HB. A UNE will also tell us if they're dehydrated. And what imaging do you think should be considered? Yep, so you're right. Both of these can be considered. I didn't think there was an option to do to be able to click more than one. So it just depends on the urgency of your investigation. So this patient has been referred to you at 3 a.m. So an ultrasound is unlikely to happen until 9 a.m. in the morning. A CT will happen at any time of night, depending on the clinical need. So with this patient, where we're thinking they've got loin to groin pain, they've got haematuria, and their apyrexia, will probably want a non-contrast CT to assess if there's any stone burden that's causing the pain. So you check his drug card. What do you think is the best management plan for his analgesia? Regular analgesia only, both regular and PRN, or just strong PRN? Cool. So most of you said regular and PRN. So regular is going to give him a background amount of analgesia, and PRN is if he has any breakthrough pain. And then we can adjust our regular analgesia based on how much PRN he's having. And if you could only choose one, what analgesic would be best to consider in this patient's situation? Great. That's really good. Yeah. So we're thinking this patient might have a stone because they have loin to groin pain. The best analgesic for stone pain is diclofenac. You can also give it intramuscularly. Or Oromorph is also a good option because he's in a lot of pain. He's saying that this is the worst pain he's ever experienced. So we want to treat it well. Fentanyl and subcut morphine probably not the best idea in this patient, and paracetamol is just not going to cut it. Okay, and so just thinking holistically, so you check his drug card. What medication is worth stopping if it's safe? So considering that he has hematuria, yeah. Great, yeah. So warfarin. Essentially, he's actively bleeding, and warfarin is going to continually thin his blood. So if it's safe to stop his warfarin, remembering earlier on that we said that he has a metallic heart valve, then it's a good idea to stop it to see if that helps stop the bleeding. However, if you've checked his INR and it's not really safe to stop it, then don't stop it because there is obviously a risk of clots. Okay. So I think we mentioned one of the causes, but you can provide any type of differential diagnosis of hematuria. Great. These are all great. All correct. So well done, everyone. So yeah, so there are a number of causes of hematuria. I'll just let you guys continue. Okay, so just going back to the presentation. There are a number of causes of hematuria, and it's often a good idea to classify it. So you can classify it systems-based, anatomically, or with your surgical sieve. So we've used a surgical sieve in this scenario. Infection can cause microscopic hematuria. We've obviously mentioned stones because this chap most likely has stones based on his history examination, and yeah, based on his history and examination. Malignancy in this case most likely will be painless hematuria. People mentioned nephritic syndrome, so yes, intrinsic renal disease such as glomerular nephritidase can cause hematuria, and then trauma. So there's a number of causes of hematuria associated with trauma. So catheter-associated trauma, if there's been a traumatic catheterization that's causing urinary retention and hematuria, you might want to consider putting a three-way catheter in and using it to do bladder washouts to wash out any clot retention. Other types of trauma are your kind of blunt force trauma, falls or crush injuries, and that can cause bladder rupture, urethral rupture, Yeah, so you would be thinking about those causes if there was a history of trauma. And when to escalate. So often it's a good idea. Obviously, you're clerking this patient in, so you need to inform your reg because they need to review them to give a secondary plan. But mainly when you're assessing the patient, if they are currently unstable, that's a good idea to involve your senior, and if this patient is post-operative as well. So just moving on to our third case, which is surrounding biliary and the biliary system. Okay, so this diagram just shows the main kind of biliary pathology that you'll be faced with in your day-to-day surgical on call. So mainly, you'll probably be faced with this more if you're on the surgical take. Okay, so I'm not going to try and teach you to suck eggs, but just going through it, biliary colic, you've got gallstones, the gallbladder is contracting around them, and that's causing pain. And it's colicky because it comes in waves. Then you've got your cholecystitis, that's infection or inflammation of the gallbladder itself. That can happen with or without stones. You've got your CBD obstruction, so when a stone comes out of the gallbladder, lodges itself in the common bile duct and causes obstructive jaundice and pain. And then when you've got infection or inflammation associated with that, you get cholangitis. Okay, so going into the case, so I think I've missed it. Yeah, so at 4:30 in the morning, you're called to review a 49-year-old lady. She's arrived in SAU and needs to be clerked. She's got right upper quadrant pain, she's jaundiced, and she's been accepted by the surgical reg. So what are you going to do? I think everyone knows the answer. Your A to E assessment, because I already showed you the slide, but you already knew it beforehand. So your A to E assessment is the most important thing. You've got the most important tool in your arsenal. So she's talking to you. You know that her airway is patent. From a respiratory point of view, she's not tachypneic. She's got normal sats on room air. Cardiovascularly, she's slightly tachycardic and she's peripherally shut down. Her cap refill is 3 seconds. She's got a GCS of 15. She's apyrexial. She's not diabetic, and you notice that she's jaundiced. So from this, we know that she is slightly dehydrated because she's tachycardic and she's peripherally shut down. And we also know that she's jaundiced, and most likely it's an obstructive jaundice picture. So from the history, we know that she's had 4 days of right upper quadrant pain. It's been constant and worsening. Her daughter's noticed that she's got yellow skin, and she says she has dark urine. She's got pale stools. She's nauseous, but she's not vomiting, and she doesn't have any signs of infection. Past medical history, she's overweight and she has gallstones. She's not a smoker. She's not a drinker. So ED have sent an FBC, LFTs, UNE, amylase, and albumin. You think that she might need to go to theatre for her gallstones. So what else do we think that we need if we're going to send a patient for surgery? So going back to Mentimeter. So the code is here. Sorry, I don't know if this is one where people respond. Oh, great. Excellent. Okay, these are all really great answers. So she's not had a clotting and she's not had a group and save. And if she's going to theatre, she definitely needs both of those. People have mentioned an ultrasound, which is great because that's the best imaging to assess for any kind of biliary pathology. Well, initial imaging anyway. Okay, great. So looking at her results, she's got a normal hemoglobin. Her white cells are normal and her UNE is also normal. However, she's got deranged LFTs. Her bilirubin is 150, and her gamma GT is 110. Her ALP is 600, and her AST is only slightly deranged at 43. So you notice that her biliary markers, ALP, gamma GT, and bilirubin are elevated. Her clotting is also normal. So what does that tell you? So what it tells me is that she's got some sort of obstructive jaundice picture because her bilirubin is high. She's got raised biliary markers. ALP is higher than AST, so that tells me that there's something wrong with the bile duct itself. Her white cells are not, I don't think we have a CRP, but we can assume the CRP is normal. So that tells me that it's not an infective picture. So it's useful for our differential diagnosis. Okay, great. So I'll just start the next question. So what do you think is the best initial management plan? This patient who's in pain and she's nauseous. Great. I think most of these answers are correct, but one is more correct than the others. She's in a lot of pain. She needs analgesia. She's nauseous, so likely if she starts vomiting, she'll need antiemetics, and it's good to write them up anyway. You can put a cannula in and you can make her nil by mouth because it's 4:30 in the morning. She's going to likely need imaging in the morning, and there's no point sending her home for 2 hours just to come back in the morning. You need to let your seniors know that you've seen her because they need to clerk her and they need to give a secondary plan, and she might need fluids and a VTE if you're admitting her. So the next question is, what is the next best imaging? I know some of you have already mentioned it. Great. Okay, so most of you said ultrasound, and some of you mentioned it earlier on as well. So in this patient who likely has some sort of biliary pathology, and we don't really know what's going on yet, so ultrasound is a lot better than CT for examining stones. And then we can move on. If we have issues with visualizing it, then we have other investigations that we would use before we would go for a CT. So this slide just mentions that an ultrasound is likely to happen at 9 a.m. We don't tend to do ultrasonography overnight, so it's something that you'll need to hand over to the morning team. So let's say that you are now the morning team. The ultrasound showed dilatation of the common bile duct of 15 millimeters. There's a filling defect in the common bile duct as well, and there's gallstones in a gallbladder that doesn't have any thickening. So just for your learning, a normal common bile duct diameter is less than 6 millimeters, and then you add a millimeter for every decade over the age of 60. And if they've had a cholecystectomy, it should be less than 10 millimeters or less. So if in this scenario it showed gallstones and a dilated CBD, but no filling defect or stone in the CBD, what imaging would be best to request next? Great, so most of you said MRCP. So MRCP is just magnetic resonance cholangiopancreatography. So it specifically visualizes the biliary tree, and it tells us if there is stone in the common bile duct, and that can inform our management from there. So what do you think is the most likely differential diagnosis in this case? This patient is not really showing an infective picture, and they have a filling defect in the common bile duct. Great. So most of you said CBD obstruction. So this patient, they have normal white cells, they've got a normal CRP, they're apyrexial, they've got right upper quadrant pain, and they're jaundiced. So I'm thinking more about CBD obstruction. The ultrasound showed a filling defect in the common bile duct. So likely there is a stone obstructing the flow of bile out of the common bile duct, and that is causing her pain. So just to go over the slide again, and then our final question is, how would you definitively, what would be the first step of your management in this patient who has a stone in the common bile duct? Great. So most of you said ERCP. So ERCP is endoscopic retrograde cholangiopancreatography. What that means is, I mean, most of you probably know this, that you put a camera through, you examine the biliary tree, and then you perform a sphincterotomy to remove a stone, and then the flow of bile is unimpeded and the jaundice should resolve. So for you guys, the most important thing to know about, rather than knowing, I mean, obviously you should know that ERCP is necessitated if there's an obstruction and if there is a stone in the CBD. But what you need to know is what is important to put down on a request form for an ERCP, because that's what you guys are going to be doing. So because they perform a sphincterotomy sometimes, because they sometimes perform a sphincterotomy, that is increasing a risk of bleeding. So you need to put down if this patient is on any anticoagulants, if they have any coagulation disorders, if they are on any kind of blood thinner at all. You also probably need to put down most of their medications and their allergies. Those are the main things that you need to know. You need to know exactly what this patient has and any imaging that you've requested beforehand. That's all important stuff to put down on an ERCP request form. You don't need to be the one to make the decision to go to ERCP. In fact, it's a senior decision, but you need to know what you're going to say about this patient. And then for patients who are fit for surgery, for a surgical procedure, then definitive management is removing the gallbladder itself. So you would do a cholecystectomy. And more often than not at the moment, most people, more often than not, it's a laparoscopic cholecystectomy, but you can also do it via an open procedure if there's any complications intraoperatively. For patients who are not fit for a surgical procedure, ERCP may be the ceiling of care in their case. If they have a perforated gallbladder, then you can cite a cholecystostomy to relieve that. So this is just kind of covering what we've already discussed and some other things that we haven't discussed. I won't go too in detail because it's not really that relevant for you guys. And this is just a summary on the different types of biliary pathology, what investigations are necessitated, and the main management. And you can go back to this at a later date and screenshot it. Okay, so moving on to our next case, our penultimate case. I'll just quickly go through these slides. Okay, so it's a 25-year-old lady, 2 days of right iliac fossa pain. You do your A to E assessment. You note her airway's patent, she's talking to you. From a respiratory perspective, she's fine. She's not tachypneic. Her SATs are normal. Cardiovascularly, she's slightly tachycardic at 105, and her blood pressure is slightly hypotensive, 105/78. And let's say her temperature is 37.8, so she has a low-grade pyrexia. What kind of things are you thinking about in this patient with right iliac fossa pain? And you guys can just think about this when we go on to the next slide. So essentially, a good way to kind of classify abdominal disorders is by dividing the abdomen into 9 quadrants. And your right iliac fossa contains your appendix, your cecum, the ileocecal junction, And if you're a lady, if you have female reproductive system, then you will have a right ovary and fallopian tube, and everyone has a right ureter unless it's been removed. And so the main differentials that we're kind of thinking of in a patient like this are appendicitis, because she has 2 days of right iliac fossa pain, and it's quite common in this age group. The main things that we'll be thinking about is maybe periumbilical pain that moves to the right iliac fossa, and again that is to do with the embryological development of the fetus. So the position of the midgut is periumbilical, and then when you get local inflammation of the appendix, you get pain in your right iliac fossa, and not wanting to eat, episode of loose stools, and some episodes of vomiting, and then examination findings such as your Rovsing sign and rebound tenderness. You never want to forget about people who have female reproductive system. You need to never forget about ectopic pregnancies, because that can be catastrophic if it's missed. So you need to know, have they had a positive pregnancy test? When was their last menstrual period? Ectopic pregnancies usually present in the 6th to 8th week of pregnancy. Do they have any referred pain to the shoulder tip? Do they have they had a history of a stark, scanty PV bleed? And they may have bowel and urinary symptoms. Other things to think about: if people have ovaries, then they may have cyst rupture, they may have torted ovary, infection, stones, like we mentioned before, and with that you get lower urinary tract symptoms and a history of fever, and they might have renal angle tenderness if they've got pyeloneph. You also be thinking about diverticulitis, although it's more common to find that pathology in your left iliac fossa, less common in this age group, but they may have a fever and raised inflammatory markers. A hernia, inguinal hernia, so you palpate the abdomen, you look for a palpable mass. Is there a cough impulse? Is it reducible? Can you hear any bowel sounds? And in people with testicles, you never ever want to forget testicular torsion. Pain can be referred to the abdomen in testicular torsion, and if you miss it and you've not examined the testicles, then it's a life-changing thing for that patient. So with regards to some, again, I'm not going to teach you guys to suck eggs because I think you probably already know how to take a history, but obviously your pain history is really useful in characterizing the differentials for the cause of the pain. Investigation wise, so your news score is really important, but a number isn't as important as knowing actually what are the vital signs that you're looking for. So your news includes their conscious state, rest rate, heart rate, temp, SATs, and blood pressure. It's more important to know what each of those parameters is doing rather than being told that they have a news of 7. So always ask for more information when you're told about an unwell patient. And midstream urine, always useful, but you might not get that result for a few days, so it's always good to get a urine dip. Pregnancy test, really important to rule out an ectopic pregnancy. And obviously bloods are important in any case. You will get a set of bloods for any patient, but more specifically, full blood count will tell you if there's any infection going on with their white cells and their neutrophils. A UNE will tell you if they're dehydrated or any electrolyte abnormalities that might be causing the abdominal pain. CRP again if they've got an infection. Group and save if they're going to theatre. Clotting if they're going to theatre. And a VBG will tell you their lactate if they have any acidosis. And it can tell you a quick HB as well. And again, imaging. Ultrasound is useful when you're thinking about ovarian pathology, and if you're thinking about ectopic pregnancy, so you do a transvaginal ultrasound. A CT is useful in appendicitis, a contrast CT is useful in appendicitis, and then if you're thinking about renal calculi, you'd want to do a non-contrast CT. But again, the main things that you're going to be doing is these kind of initial bedside tests, such as your blood, your pregnancy test, your urine dip, and knowing what the news score and the parameters are. So with this patient, we know that she's got a leukocytosis, her white cells are 16, Her CRP is 235, which is raised. Urine dip is negative, but sometimes you can get nitrites in appendicitis, and the pregnancy test is negative as well. So coupled with the history, the examination, these bloods, it points us towards a history of appendicitis. So you would then escalate to your senior, who would most likely recommend a CT abdomen, pelvis, to confirm the diagnosis of appendicitis and if there's any complications such as a fecalith or perforation. Okay. Sorry, I think I've missed something. Sorry about that. I think so. In this lady, she's had a 2-day history of right iliac fossa pain. She's been nauseous off her food. She had 1 episode of loose stools, no blood in the stools. Her A to E is mainly normal apart from her tachycardia, and she's tender in her right iliac fossa and guarding, and she's Rovsing's positive. So we are thinking about appendicitis in this lady. Okay, so our final case. I hope you're all still with me and you're still awake and still enjoying the presentation. So most of you will have general surgery placements. Some of you may have vascular placements, but on some of your general surgery on calls, you'll be asked to see vascular patients depending on your trust policy and how they delegate who you cover on your night shifts. So let's say you're the F1 and you're on your night shift and it's 11 p.m. and you get called to see this patient. They're a 55-year-old chap. They're screaming in pain and you can hear this noise in the background when you're speaking to the nurse. They're desperate for you to come and perform an urgent review on him because he's making so much noise. You agree to see him, but you need to ask some questions first. So you ask about his news score and specifically the parameters, like we said earlier. If why he's been brought in, what is his background, has he had any analgesia? So they explain he was brought in for management of an ulcer on his right foot. He's got a wide range of CV risk factors. He's a smoker. He's got type 2 diabetes. He's had a AAA repair 5 years ago. And he's only had some paracetamol. So when you're on the phone, you can ask the nurses to do investigations while you say you're going to come and see them. So you ask the nurse to please perform an ECG. So you arrive on the ward. The nurses say, "Oh, please review this patient, doctor." And you do your ATE assessment. So everything you do your ATE. So you come into the room, you see that he's screaming. He's sat on his bed, his blankets are on the floor, he's clutching his right calf, he's in agony, and he's begging you to help him fix his pain. So you start off with your ATE. Obviously his airway's patent, he's screaming at you. Breathing, he's tachypneic, he appears to be hyperventilating and his sats are low. Other than that, on auscultation, you can't hear anything else. His trachea is central and there's no percussion changes. You've seen the ECG that the nurses have kindly performed and you see it and you see that there are no P waves and it's irregularly irregular. So you're saying this patient is now in AF. You check his pulse to confirm and it's fast, irregularly irregular, and it's around 110 beats per minute. His blood pressure is high, it's 170/110. Cap refill is 2 seconds, and he's not catheterized, but he tells you through his screaming that he's not been urinating as much as normal. So at this point, you probably want to check if he's got IV access. You probably want to take some bloods and get a blood gas. So you go on to D, his GCS is 15, pupils are equal and reactive, his temperature is 36.2, and his BM is 5.9. You examine his abdomen, it's soft and non-tender. You note that he has a AAA scar. There's no skin changes above his pelvis. You look at his legs, and his left leg is completely normal. However, worryingly, his right leg is pale, cold, and painful from the patella down to the foot, and he has no sensation. And you check his pulses and you can't palpate the dorsalis pedis or the post tib. And despite you doing soft touch and sharp sensation, he can't feel you touching him in his toes. So moving back to Mentimeter, and then the code is just at the top. Okay, if anyone wants to mention the 6 P's, great. Okay, great. And they're all different, which is great. Good. Very good. Excellent. All these are correct. Very good. Really good, guys. I'm really impressed. Okay, so yeah, so in acute limb ischemia, which is what we suspect this patient has, it's always important to remember the 6 P's. So like everyone said, pain, paralysis, pulselessness, pallor, paresthesia, and being perishingly cold. So just going back to the presentation, that's just our A to E assessment. Oh, sorry. Actually, going back to the Mentimeter. So let's think about what our differentials might be. So we've already mentioned acute limb ischemia, but what else could be going on in this patient who has right limb pain, and it's severely painful? Yeah, great, good. Yeah, I'll just talk through it. Okay, so someone said compartment syndrome, which is correct. So we would be suspecting compartment syndrome. They'd have pain out of proportion to their, their clinical signs, and they probably have pain on passive stretch. So what kind of differentiates compartment syndrome from acute limb ischemia is that this patient might have had some trauma to the limb. They may have had surgery to the limb, or they might have a plaster cast over the limb, or anything that's kind of restricting the limb itself, and that would likely point us towards compartment syndrome. So in this case, we can probably move away from it, but we want to discuss with our senior just to make sure that it's not compartment syndrome. Someone else has said DVT, which is great. And what can differentiate this presentation from a DVT presentation is that this patient is cold. In a DVT, likely the leg would still be warm, and you'd still be able to feel a pulse on a Doppler. Other things is CVA of the limb can have a lot of the P's, but the 2 factors that kind of separate this from acute limb ischemia is that you can feel Doppler pulses in the legs, and the patient won't be in pain as well. Okay, and another thing that we want to consider is hypovolemic shock, which is all mentioned on this slide here. However, in this patient, it's only affecting his right limb, and in hypovolemic shock, because it's a systemic response, we'd expect all the limbs to be affected and peripherally shut down. Okay, so going back to the Mentimeter, sorry, I know it's a lot of moving backwards and forwards. There's a few questions to ask. So what I'll do is I'll go through these questions, and then I'll go through the slides and explain why the answers are why they are. So I won't explain it while we're going through these questions, but I'll do it when we're going through the slides. So this patient has acute limb ischemia. What analgesia should you avoid prescribing in this situation? Yep, so the majority of you have said NSAIDs, and I'll explain why later on. Oh, sorry. What is the gold standard investigation? Yep, the majority of you said CT angiogram in a patient with acute limb ischemia, which is absolutely correct. And then finally, Last question, and then we'll just go through. What scoring system do you know for acute limb ischemia? Cool. So it's less well known, but we can discuss it later on. It's not something that you need to really know too well, because mainly you're going to be dealing with just the fact that they're acutely unwell, but we'll discuss it in the slides. Okay. So initially managing this patient, you obviously need to immediately escalate to your senior. So you've done that, but in the meantime, you can do certain things. You can give him oxygen because he's hypoxic. So just pop him on 15 litres non-re breathe and then titrate down as appropriate. He's in a lot of pain, so give him some analgesia. You can give opiates and neuropathic agents, and that should hopefully help. You want to avoid NSAIDs. Evidence shows that NSAIDs increase the risk of myocardial events in patients with acute limb ischemia. So just avoid those. You can give morphine. You can give neuropathic agents. You want to treat his if he's got any dehydration. You want to give him some fluids. Avoid Hartmann's or anything that contains potassium. You already probably have some red cell death, so potassium, there'll probably be a hyperkalemia, and also giving him potassium is going to worsen any ensuing AKI. In terms of anticoagulation, he's probably already on some low molecular weight heparin because he's a surgical inpatient, and it will be prophylactic, but he needs IV unfractionated heparin. This will be a senior decision, so you should probably just check in your department. Are they happy for you to give the unfractionated heparin? Is that something that you would normally do in your department, or do you have to wait until the senior assesses the patient? So you would give IV unfractionated heparin. Calculate his Rutherford score. So that's the scoring system in acute limb ischemia, and we'll discuss that in one of the later slides. And obviously they need immediate vascular reg input. So you would escalate to your registrar. Depends what your hospital trust is. If you're in a DGH, you might not have a vascular unit. So you would escalate to your surgical registrar, and you'd also call the on-call vascular reg for the area as well. If you're in a teaching hospital, you likely have a vascular reg, but they might not be on site. So again, you'd call them, and you'd also call any senior that is currently on site in the hospital. Okay. Investigation wise, while you're waiting for your senior to come, you can take some bloods, and obviously, sorry about that, an FBC will show if there is a low HB or if there is high platelets. A UNE might show high potassium and dehydration. We'd do an ABG to look at the lactate to see if they have any critical ischemia. We'd look at the ABG to also rule out some acidosis, and there would also be glucose level on there as well. Creatinine kinase can indicate if there's rhabdomyolysis. Clotting obviously relevant for the heparin prescription, and also relevant for theatre. With your heparin, there's different investigations that you would do to monitor the heparin levels, but that's not relevant for your acute management. Group and save, because they might need intervention. Well, they'll need interventional radiology or theatre. You've asked for you might have asked for an ECG, and you think if this patient has AF or any arrhythmias, or they're currently having a concurrent MI. Imaging wise, so gold standard investigation is our CT angiogram. So you want to identify where the clot is. CT angiogram is the gold standard, and it will display compromised blood flow in patients and can help you identify anything else abnormal contributing to his disease. If you're unable to get a CT angiogram, you can get a normal CT as well to classify. And then you can also do a duplex scan, but again, this is operator dependent. And obviously it's not something to learn in the acute setting, but you can learn if you're on a vascular job, you can learn later on. And then just going through the Rutherford score quickly. So it's a complex score. It has different parameters of what constitutes the different limb outcomes. So essentially there's different categories, tells you the limb outcome for each category, the initial management, and then the definitive management. Obviously, definitive management is not something that you're going to be doing but initial management is something that you will be doing. And obviously, in all cases, you need to escalate to your senior. In this case, you notice that he has pale cold, severe pain, right leg from his patella down to his toes, and he hasn't got sensation to both soft and sharp touch. So that suggests that he has category 2A limb and would likely require CT angiogram and most likely immediate surgical intervention by the morning. But this isn't something that you need to really be that aware, just be aware of it, but you don't need to know it in that much detail unless you're planning on becoming a vascular surgeon. So that's the end of that case. And then just a quick slide on task prioritization, because it is really important to be able to prioritize your jobs when you're on call, but even when you're on a normal day. This is particularly if you're on a night shift. So at the start of the shift, you can let the nurses know if they can write on a sheet of paper any non-urgent jobs. So not urgent jobs, non-urgent things like if you need regular meds prescribing, or anything that's not required for you to go and see that patient immediately. And then let the nurses know that you're going to come and check the list every couple of hours. If you're asked to see a patient with chest pain, always ask for an ECG when you're on the phone. It's really important because when you get to see the patient, you can just look at the ECG. And then always try and specify a time frame when you're asked to do something. And obviously it depends on the urgency of the task. So if you're asked to review an unwell patient, just say, I'm going to be there. If you're already reviewing an unwell patient, classify which one is more unwell, who needs your help more. If they're about the same and you're already with someone, you can try and stabilize them first. Ask if they can call your SHO. Ask if they can call your registrar, if there's anyone else who can see this other patient. It's about having some common sense. And to be honest, that will just get you through most of your on-calls. And yeah, so we're on social media. So that's the end of the presentation. I hope you enjoyed it. I hope it was useful. I think it's useful for anyone really. Medical students, foundation trainees, it is really important to know these things, the common surgical pathologies that you'll come across in your on-calls and on the wards. It's useful to know, even if you've not got a surgical rotation this year, you might have one next year. And it's useful to know, and obviously all these things are kind of basic because you're not going to be performing the surgery. You're not going to be doing any of the kind of definitive management stuff. You're going to be assessing the patient in the acute setting. And it's really important to know what you need to do, because sometimes you can come to a patient and just lose your head a bit because you're stressed. This patient's really unwell. There's so many things going wrong. But if you look at it with a clear head and think, I'm going to do my AT assessment. I'm going to give the initial management. I know the limits of my competence, so I know when to escalate to my senior. That's all you need to know. So yeah, I hope you enjoyed it. If you want to follow us for our future events, we are on social media. We're on Twitter. We have a Facebook group. If you have any questions, you can email us on our email address. And to be honest, we'll probably check the Facebook and the Twitter more often if you have any questions. And then we have a mailing list for any of our future events. So yeah, so just have a look and see. Just to see what we're doing in the future. I think someone's already asked if there's any activities or events that people might like to see in the coming months in the comments, but if you have anything, then please email us or tweet us or message on the Facebook group. We're really willing to accept anything because we want to make sure that we teach you exactly what you want to know. It's no good as making things according to our whims. We basically do things for you. So just email us, let us know. Really interested in hearing your guys' opinion. Okay, yeah, so sign up to our mailing list. And also, one of the registrars has mentioned, if anyone is interested in having a mentor, if you're interested in pursuing a surgical career, just let us know, and then we can put you in touch with the right people to find a mentor. Okay. And please, please, please fill out feedback forms if you attended. It's really important for us because we know what we've done wrong, or well, not what we've done wrong, but what we can improve upon. And it's useful, you know, in your career, you'll notice everyone asks for feedback, but it's not just kind of a tick box exercise. We actually look at the feedback and we amend our teaching styles and what we're teaching and our content and our knowledge based on what you guys are saying. So please fill in the feedback forms. This is the link. If you can, if you guys can take a screenshot of it, or I'll post it on the social media pages. It would be really useful if you guys can give us any feedback. If anyone has any questions, you can message in the